Once you've defined this baseline of outcomes and cost, then we can talk about, well, here's what we'll do to improve that. And once we do that, you're talking about a language that you can deal with. You can quantify the level of improvement. You can then create a business model. And no matter what and how difficult the administrative issues are, if you start with that, it's going to be easier than if you don't. It's just as simple as that. If you go in with a concrete proposal, this is what I'll do, and I have the confidence to sign up for it and defend it, I think no matter what you request, that's easier to do than say, hey, give me some money, I'll do good things. Yeah, that never works. These are some specific examples of areas that we're developing offerings, some more mature than others, some already commercial, others, we're still in the early stages. But I'll really walk through three specific examples. The first is the simplest one, and this is the simplest value-based healthcare model that one can think of. It is a therapy optimizer. This is not a whole episode. This is a therapy optimizer in the therapy of different implantable devices. And the episodic care could be to do with cardiac rhythm conditions of different sorts. And you have to go through that whole process of selecting cohorts and so on. But in this specific optimization, patients who need an implant, a cardiac implant of some sort, and who have a risk of infection, which is in the reimplantation case when people need their devices to be removed and replaced, is unacceptably high usually. It's anything between 2 and 4%. If you put this antibacterial sleeve on top of this product, we've shown with clinical data that you can get almost no infections at all. And so that's the overall backdrop. It's an antibacterial sleeve that goes on an implant that prevents infections. There are 2 points I want to make. First, it struck us that something which is really a small piece of healthcare and a little optimizer in one therapy on a very specific cohort of patients, people who want reimplantation of cardiac devices, which is a fairly small cohort. The actual cost of infection and the consequences of infection are actually very high. In this example that I've shown on this page is for a specific pair in the United States, and it cost them $35 million for that pair, for these infections. But there's a 50% mortality rate in 3 years of these patients. So you don't want them to get infections. We did the same study actually for all the Medicare population in the US, people above 65. That happened to be 130 million. The reason I say this is because it tells you that there's a lot of money that's wasted and a lot of money that can be saved for something that's, one wouldn't think of as the biggest problem in healthcare and wouldn't even address unless you really thought about it. And if you just prioritize the biggest problems, you'd never get to this. However, there's money here. And if you save that money, you can use it for something else. You can use it for chronic care management improvement. You can use it for other complex conditions. That's the whole concept of reducing wastage. The other point I want to make about this is the fact that if I put it in value-based healthcare terms, it's actually very simple. Here, the cohort is very straightforward. It's patients who are getting implants, reimplantation. That's the cohort. In this case, it's not even a specific disease, it's a condition. These patients have cardiac devices of some sort, and for a variety of reasons, those devices need to be replaced. And it could be battery wear, it could be some other problem, it couldn't have been put right in the first place, there's a variety of reasons. That's the cohort. The care pathway is very simple. You just put a sleeve on an implant. And, the implant itself, there's a care pathway, but one is assuming that that's done in the right way. You put a sleeve on that implant. The outcome measure is even simpler. It's black and white. You have an infection, you don't. The business model is, again, straightforward. If there's an infection of any sort, we'll pay for the entire cost, not for the product alone, but for the entire cost of the procedure, for the entire cost of readmission. That's the business model. How do you calculate the savings? You see what the cost was for that institution for this type of infection in a year. In next year's budget, take that to zero. That's the savings you get. This is a very simple business model, but even this is one that we run into all kinds of hurdles if we try to implement. For a start, one that is almost amusing, but really isn't. You go to a hospital system, specifically in the US, where people get paid for procedures. Doctors actually think this is the right thing to do because they look at the mortality rates, they sort of intuitively understand the sort of risks of infection and all of that and say, this is very easy to do, good data, we should do it. They've got to pay for it though. Someone's got to pay for it because they get paid for buying things. They don't get paid on outcomes. So you eventually work your way up to purchasing or administration or somebody. And they look at their math and say, well, actually, this is not a big cost to us because, when patients come back, we get paid again. They get reimbursed again. So when they look at their net cost of infection, it actually isn't that much because every time a patient comes in for readmission, you get reimbursed for it. So it doesn't really cost them too much money, if anything. So that was an eye-opening experience. It should have been obvious, but it was clearly eye-opening. When you have the same conversation with a payer, that's a different conversation. Payer opens their eyes and says, wow, there's $35 million here, or $130 million here. For something as simple as this, well, let's find a way to make this happen. That's why you got to do all the basic steps. But even in the business model discussion, it isn't always that easy. You got to go to the right place to get the right benefit. You can walk through in your own institutions how something like this would play out. The second example I'll give you is acute care, and CABG is an area that we're working on. Again, here the cohort would be a person who's identified for cardiac surgery. The first thing you'd do is risk stratify. And you'd have different care pathways. I give some examples of that. We have various technologies and so on that we can do, but there's lots of things that are not on this page. There's the technologies that may be required to do the risk stratification. There may be technologies that are required to do things like discharge planning. There are technologies that may be required to do the outcome measurement, to define the outcome for specific cohorts and to do the measurement itself. There may be technologies in remote monitoring, some of which we've listed on this page. CABG is also an area that we're focused on. This is much more in progress for us, but it's something that we want to highlight as an area that, working with cardiac surgeons, develop a 90-day package and maybe a year package, depending on how the payers react to this, over which one gets a fixed payment for a specific cohort. The payment may vary depending on the nature of the cohort, or if an institution is broad enough, we can average that. And we're working this. So this is a second example. The third example I'll talk about is diabetes, type 1 diabetes, a pediatric population. And here we've actually got a business model in the Netherlands which has been functioning for the last couple of years, where we actually provide care through 2 doctors and some clinicians who provide care to pediatric type 1 patients, and we've had outstanding results. Here, the outcome measures that are meaningful for patients have been defined. Glucose control, the level of A1C, the number of hypoglycemic events, the number of hyperglycemic events, the amount of hospital admission, the type of patient satisfaction. All of those are defined outcome measurements which were in place. We have a business model where an insurance company pays us a fixed amount per patient for these patients, and that amount is reviewed every year against the outcomes that we've achieved. And if we haven't achieved those outcomes, future payments will be adjusted based on our ability to deliver the outcomes that were promised. Outcomes are important, but we thought that we'd at least make an effort to categorize the different types of outcome measures, some of which are completely objective and should be there in every situation. Others are more subjective. Clinical outcome measures are the most objective. If you cannot define a clinical outcome measure, you've got no business in developing a care pathway or doing an intervention. You may do spinal fusion, in which case you do a scan at the end to make sure that the fusion has occurred. You may do diabetes management, in which case you look at the A1C levels. So clinical outcome measures are ones that really answer the question, has the procedure met the expectations from a pathophysiological perspective? And this should be objective, quantitative, and expected, because there's a goal for that procedure, and it depends on the cohort that you're dealing with. Complications and so on all fall in this category. Functional outcomes are related to the clinical outcome, but different. This defines how a patient feels, how the patient's life got better as a result of that intervention. This is not patient satisfaction. This is a measurement of their functionality, which was supposed to have been improved as a result of the procedure. It could be everything from I couldn't walk anymore to I can walk now, to I can climb a flight of stairs and I couldn't before, to I don't have pain now and I used to have pain. I can flex my arm a certain degree, which I couldn't do before. These are functional measurements, but they are a direct result of the intervention that was performed. So this is not subjective. This is measurable. It can vary, and even the goals may vary depending on the patient who you're treating, but it is not something that you just pick out of thin air. And it's not something that you measure, that doesn't have an objective measurement, that cannot be looked at in a consistent way. So this functional measurements come second. And then you have patient satisfaction, which actually is important. You know, you do all of this, and a patient does all of that, but is not happy, is depressed, and so cannot go back to work. And that's not a satisfactory outcome. Or a patient who's supposed to be relieved of pain and is relieved of pain for the treatment that was provided, actually still has pain, but for some other reason. Or a patient who's just simply unhappy with the whole experience and cannot deal with it for whatever reason. These measures all have to be in place. Now, the consequences of these measures may vary, and the weight and importance of these may vary. And the ability to kind of be precise about them will almost certainly vary, because these are opinions. But it's something that you cannot walk away from, and in extreme cases are completely unacceptable, even if you do the clinical and functional, reach the clinical and functional outcomes. And then the fourth measure are surrogate measures, things that are a result of the first three, things like readmission rates and length of stay. I mean, those are a result of the clinical procedures, you know, either not working right or working in different levels, and those are measurements. You can argue whether they're clinical measures or cost measures, but in the end, they're not direct measures of outcome, they're surrogate measures of outcome, and many times that's the only thing we can do, which is fine, but you just got to realize that to act on it, you got to figure out why, and then you've got to go to the more fundamental measures of outcome.